Hello guys, in this video we are going to see about general surgery and trauma. Okay, in general surgery, let's start with the suture materials. In the suture materials, there are two types: observable and non-observable. In observable, there may be synthetic and natural. Here also there is synthetic and natural. In natural, we use catgut, which is derived from sheep gut by hunter to use for over 60 days. Okay, in 60 days it will be divided. Then another is the chromic catgut. This will be useful in submucosal sutures. This chromic catgut will be up to for 90 days. This will be useful for pubectomy. Okay. Then synthetic. First we will see monocryl. Okay. It is made up of polygalactopron. Okay. It will be useful in subcuticular sutures. Subcuticular. Okay. Then second one is PDS, polydixon, which is useful in Whipple's procedure. Okay. Then third one is Vicryl, which is nothing but polygalactone, which is useful in this CBD, bowel, and ureter surgeries. Then fourth one is Dexon. Dexon is made up of polygalacticol. It will be useful in, it will cause more risk of infection is there. Okay. Then in this non-observable synthetic, there comes epilon. Then second is proline. Then Novafil. Then bond. Natural there is silk. Yes, epilon is useful for nerves and muscle spindles. This food is also useful for mesh repair and rectus sheath repair. Okay. The most commonly used. Here you should know the days. This monocryl will be useful for 180, 120, 90, 90. Okay. Then this Novafil is there. Then this is not used. Ethibond is there. So this is nothing but polyester. Okay. Then let's then know about other things. Okay. Mattress suture, when you need aversion of tissue, you will do mattress suture. There are two types of mattress, vertical and horizontal. Then you can do simple continuous suture. Okay, at last there will be D knot, some D knot. Then simple interrupted suture. Then I know subcuticular, where this monocryl will be useful. Then next we'll next important thing is there are types of drains. Is there type of drains? Rotovac, Romovac. Then we can use Pratt. Then Epithel is there. And then Cutman, Manicut. Okay. Four types of drains are there. This is in mastectomy and and thyroidectomy. This patch is used in abdominal surgeries. This is in abscesses. This for suprapubic cystotomy. Okay. Then urine. There are two types of bags: urine bags and chest drainage bag. Okay. But they need to know about the post-op fevers. Post-op fever. That's ceremony is there. First is wonder drug, then wind, then water, then walking, then wound. Wonder drug is this is hyperthermia. It can occur at any time. Okay. Here there is no prevention, but we can treatment is giant rolling. Second is wind. It is due to atelectasis. 1 to 3 days. Prevention is by the spirometry. That balloon filling. Okay. Third one is water, which is UTA, within 4 to 5 days. Prevention antibiotics. Then walking is DVT. It will around 5 to 7 days. Prevention is by early mobilization and anticoagulants like heparin. The wound is this wound infection more than 7 days. Antibiotics and proper wound care. Okay. This is for post-op fever. Okay. Surgical site infection is defined as an infection occurring within 30 days, and for implants less than 1 year. Okay. Then we need to know about burst abdomen. Burst abdomen where the abdomen didn't close enough. Okay. There will be salmon pink appearance of the abdomen. There will be discharge, zero sanguineous discharge is the earliest indicator of it will going to become into the burst abdomen. Zero sanguineous discharge. Treatment is Brugada operation. Okay. Then next you need to know about the different types of classes of wound. There are four classes of wound, like class 4, class 3, class 2, class 1. And the class 4 is the open wounds, traumatic open for more than traumatic wound for more than 4 hours, or any perforation lasting more than 4 hours. Okay. And any rupture more than 4 hours. It is the class 4 wound. Okay. That is dirty wound. Then class 3 is the any surgery you are doing may not pre-planned into GAT or GUT or respiratory tract. It is known as contaminated wound. Class 2 is that pre-planned entry into GAT, GUT or respiratory tract. It is known as clean contaminated wound. And the class 1 is you're not entering into those GAT, GUT or the but you're doing surgeries like hernia repair, thyroid surgery, varicose surgery. Okay, these are clean wounds. You need to avoid the risk of infections. risk of infection. This for class 4 is 20%. It's here it is 2%, 2 to 10%, 10 to 20%. Okay, this is about the classification of wounds. Then next we know about the main nerve injuries that occurring during any surgery. Okay, first one is the during the breast surgery, which is the ICBT. Okay, then second one is for during thyroid surgery, the external region. No? Then during parotid surgery, three questions is there. There is when the deviation of angle, then anesthesia at angle or Frey syndrome. This deviation of angle occurs due to submandibular nerve damage. When anesthesia at angle is due to great auricular nerve. Then Frey syndrome is due to auriculotemporal nerve. Then fourth one is during submandibular surgery, the most common damage is the lingual nerve. In lap hernia is a lateral cutaneous nerve of thigh. Okay. And then open hernia, that is the ilioinguinal nerve. Then mesh entrapment is the iliohypogastric nerve. Okay. Then let's see about different types of shock. There are cardiogenic, hypovolemic, obstructive, distributive, then neurogenic. We'll see about cardiac output, systemic vascular resistance, and central venous pressure. Okay. In cardiogenic, there's reduced cardiac output. HCO is increased due to backflow. CVP is increased. Okay. Hypomyocardial presentation, this is increased. Whereas there is loss of no volume effect, so CVP also be fallen. The obstructive shock, that will be reduced cardiac output. Vascular and due to obstruction, the CVP will be raising. In distributive shock, everything will be less. Okay. No, the cardiac output is sufficient there. The SVR and CVP will be fallen. Whereas in neurogenic only, there will be loss of everything due to no action. Okay. This is about the type of shock. Then we need to know about the SIRS. It is a severe inflammatory response syndrome. There are components like pH or white T for temperature, less than 36 degrees Celsius or more than 38 degrees Celsius. That's for heart rate, more than 90 beats per minute. Then respiratory rate, less than 16 or more than 34. Then white is this one, WBC count. Okay, less than 2000, more than 24,000, something like that. Okay, there is another score known as Q-SOFA score. Q-SOFA score, where you can know the garbage. There is three things is there. What it includes, it does not include heart rate, but it includes respiratory rate, temperature, BP. Okay. Okay. Then next concept is about mm, you need to know about the triaging, where the rate is very important. Definitely needing surgery. Yellow is also need care, surgery, but within 6 hours. Green is wounded and walking, and then black is dead. Okay. Then there are primary surgery, primary surgery, resuscitation, secondary surgery, then definitive care. Okay. This primary survey and resuscitation should go hand in hand. This primary survey should be done to know the disease killing the patient. This resuscitation should be done for to kill the disease. Primary survey includes 5 steps. First one is there is ABCD. Okay, is airway plus cervical spine stabilization. B for breathing and ventilation. C for circulation. Okay. D for any disability. Okay. We don't know. Then secondary surveys. What any other causes causing any disease is there. This is the full definitive management. Okay. Then another important topic is blood transfusion. Okay, blood loss. There are 4 classes: class 1, class 2, class 3, class 4. These are based upon the blood losses. In class 1, there will be loss of about less than 15%. This is 15 to 30%. This is 30 to 40%. This is more than 40%. That is, it's less than 750 ml. This is 750 to 1.5 liter. 1.5 liter to 2 liter is more than 2 liter. In class 3, you should need to start blood transfusion. But in all classes, first step is to start warm saline 1 liter. Okay. When blood transfusion will be started here at the ratio of 1:1:1 on packed RBCs, platelets, and FFPs. For this class 4, we need to do massive transfusion. There's more than around 10 units of blood need to be transfused. Okay, we can do the transfusion. Okay, then what will be the fluid volume to be given? Okay, in adults. Okay. Then let's see about the different chest traumas available. Chest traumas. There is trauma to the tracheobronchial L3. Okay. Then there will be significant damage to the lung parenchyma causing pneumothorax, tension pneumo, then open pneumothorax. Okay, then there can be hemothorax, pleural effusion. Then there also can be cardiac tamponade. Okay. Then we need to know about the how we can manage the pneumothorax emergency. Okay. In pneumothorax, you need to know the needle thoracostomy, where in children and adults, children done at third mid clavicular line, adults fifth mid axillary line in a triangle of fifth intercostal space. Then this is the pectoralis major muscle. This is the latissimus lat dorsi. Okay, this is the triangle where I put the ICD. Okay. Then it's coming to the abdomen. Okay, abdomen, blunt trauma abdomen. Okay, first we talk about the most common organ injured in blunt trauma, penetrating trauma and gunshot wounds. Okay, in blunt trauma, the most common organ injury is stomach, penetrating in the liver, then stomach. This is bowel. Okay, this isn't sorry, spleen. Whereas as gunshot, it's the bowel is the most commonly injured organ. Okay, then there is a case of blunt trauma abdomen. What will do? If he is unstable or stable, in both conditions, you should be fast. E first stand for extended focused assay of sonography in trauma. And first, then you should do shift to OT and to lap surgery. What do you do? When this is stable, first you should be fast, and then you can go for a CECT to know any cartilage penetration or rupture. Okay, then you can plan it on OT and anything. Okay, this is for a stable patient. Then whenever there is what are the steps in fast in a chest injury? Okay, that's important. This abdomen, first you look at the xiphoid process, tranxiphoid, then you look at the hepatorenal, then splenorenal, then pelvis you look, then fourth one you look for fifth one you look for a chest for pneumothorax. This is the EFAST. Every patient should know what how to do EFAST in a trauma. Okay. Then this is for pneumothorax. Then last is the sixth one is the behind you do you look for any hemothorax. Okay. And the subcostal. Okay. Then you should know about the what are indications to shift the patient straight to OT. If he is unstable, penetrating wound, gunshot wound, impacted object like any knife is impacted on the abdomen, don't try to remove it. shove the patient with the knife to the aortic. Okay, you can remove it there because a tamponade will be around it. Like this, any rupture is affected. This you can shift directly to the OT. Okay. Then what are the retroperitoneal trauma is there? There are 4 zones of retroperitoneal trauma. That is abdomen, near the blood vessels, aorta in the left, vein in the left, right. Okay. This will be a zone 1. Then this will be the zone 2. This will be zone 3, and back side will be zone 4. Okay. If there is any problem in the zone 1 damage, there the aorta is damaged, you should do left mesentery rotation surgery. Okay. In this here side, you should do right mesentery rotation surgery. In zone 2, any problem is there, you should observation because it's kidney is damaged on there. In zone 3 is there, you should do external pelvic compression. Okay. In zone 4 also, retroperitoneal is there, anything something you need to do. Okay. Next, let's go to the last topic, genitourinary trauma. Genitourinary trauma. Let's see about the infusion of science and different things like first renal trauma in stable patients. We should see CECT, urography, CT urography. Then bladder injury, then urethral injury. Bladder injury, you should do CT cystography. Urethral injury, you should go to retrograde urography. Okay, you want to dive into the penis. Okay, then let's see the approach to genital trauma. The approach to urethral trauma. Okay. A small topic is there. You should know the class of the renal injury. Okay, there are 5 classes. In class 1, there is extra capsular hematoma. Okay, extra cap hematoma. In class 2, there is a small laceration and a small bleeding inside the perirenal membrane. Okay, then this is class 2. In class 3, there is a laceration inside the kidney and active bleeding. Okay. Class 3 is laceration plus active bleeding inside kidney. Okay. In class 4, what's happening is in class 4 there is a this is the collecting duct, okay, collecting system connection with the collecting system with the injury. So what happens is the urine and the blood mix through and will they become a fill the perirenal membrane. So that's class 4. Whereas is class 5, there is involvement of this renal artery, avulsion of renal artery. Okay, so there will be excess bleeding. You definitely go for lab surgery. Okay. These are the classes of renal injury. Let's come to the approach to urethral trauma. Mm, Investigation of choice in urethral trauma is the uh, retrograde urography, as we seen. Then we should go for initial management is with the suprapubic cystectomy. We have seen there in the starting, which catheter is a manicate catheter. Then you should wait for 4 to 5 weeks. Then uh, you can do erythroplasty. That is definite management. Erythroplasty. Okay. If they ask the urinary bladder is not palpable, then you should not do suprapubic cystectomy. You should wait and observe. Okay. Then another important topic is the hemorrhages. The different hemorrhages like EDH, SDH, SAH. Okay. This EDH is due to the injury to the thyrion. So this will not cross suture line. The vessel involved is the middle meningeal artery. Investigation of choice is non-contrast CT scan. Okay, RX is if it does not compress the brain structures, then we can observation. But if there is shifting of midline is there, you should do liquid craniotomy and remove the EDH. Okay, its shape is like a biconvex. Then STH is any trivial trauma also. Trivial trauma because it can cross suture line. The vessel involved is the bridging veins. RX large observation. Shape is concentric shape. SIH is due to the rupture of aneurysm. Rupture of aneurysm most commonly is in the location of where AC. This is ACA and this is anterior communicating artery. At this location, this rupture can occur. It will produce thunder clap, headache. That is the worst headache of life. Okay. Then let's see about the very important GCS is there. There is E4, V5, M6. 1, 2, 3, 4, 5, 6. E4 is there where the fourth one is the spontaneous eye opening. Spontaneous eye opening. Spontaneous eye opening for E3. E3 there is spontaneously they can open to speech. This to pressure. This one they don't open. Okay, don't open. Then the V5 is when they are conscious. This is conscious. This is oriented. This one they 5-4. Then for 3 they can speak words. This there is sounds. And B1 is they nothing. No, don't open mouth. No verbal. Then for M6 there is sixth one is very spontaneous. They can move. Then 5 is they can localize. Fourth one is some passive movements. This is the corticate. Cerebrate. This is no movement at all. Okay. Then the last topic is the bones. Okay. In bones, there is a first degree, second degree, secondary superficial, deep, and then third degree is there. Histo, appearance, sensation, healing. Okay. This first degree burns is only epidermis. This is epidermis plus superficial dermis. This is epidermis plus deep dermis. This third one is the all epidermis plus dermis plus it also involves the muscles. Okay. Then how they appear is in black. Okay. Blisters. First degree there will be blisters. And there will be black cherry. Okay. Then here white spots. Here white charring occurs. Here the sensation will be might be painful. This is very severely painful. This is less painful. This is no pain. Okay. Healing. This one heals quickly. This heals without scar. This heals with the scar. For this, definitely hysterectomy and graft is required. Okay. Then the last thing is you need to know about the Wallace law of calculating the percentage of bones. This is for adults where you put 9 plus 9, 9 plus 9, 9 plus 9, 9 plus 9 here, which around will become 72. Then 9 for rounds, 81, 90, 99. The last one is for the genitals. That's 100% in adults. Whereas in children, where they have a very large head, so we need to do 18 for this head. Okay. Where that 9 come from? Here we can do totally 9. Okay. Instead of 9 plus 9, we can do totally 9. No. Wait, let's put 9 plus 9, 9 plus 9. Okay. Here 9, 9. Okay. We can calculate how much is coming. It's 18, 18, 18, 72. And 72. This is 81, 90. So remaining 9 is there. It can be 4.5. 4.5. Okay. That's it. This is for children. Okay. And then management of bones. Okay. Management is the first you should IV fluid is give according to Parkland formula. It is calculated for adults, children, and electrocuted. For adults, it is 2 ml per kg per hour. This is 3 ml per kg per hour. Electrocuted is 4 ml per kg per hour. Where in the first 8 hours, we should do half the amount of fluid. On the next 16 hours, the remaining hour we should give. Okay. Then what can use for is silver, sulfadiazine, then silver nitrate. This less permeability is there. Okay, let's put is black color. Then other two is there, ceramide something. Okay. Okay, that's it, guys. Thank you very much.